Red light, green light, okay.
Here we are.
Hi, I'm Tim Pickett, and this is Blake Smith, and welcome to another version of our Brand live event for Discover Marijuana. We're streaming live on YouTube and a couple of other social media channels tonight. We're going to talk a lot about marijuana, medical marijuana in Utah specifically. We're really going to focus on mental health for the first kind of portion of this, and then we're going to get right into your questions. And we've already received a lot of questions about mental health in cannabis, the market in general, some other various topics. Feel free as we go along to ask questions on whatever social media platform you're watching on, and we'll try to get to as many as we can. We have quite a bit of time here, so let's just jump into it. Blake, I want to talk a little bit about, or focus a little bit about mental health, and when I talk about these things, I like to bring up like a patient story. I think that it brings, makes more sense to me when I talk about it that way. Mental health for cannabis really is PTSD and the anxiety disorders and a little bit of depression. I think it's about 85% of people who use cannabis report using it for anxiety, even though anxiety is not a qualifying condition in Utah. It's a huge burden, these mental health conditions on the healthcare system, and it seems to be that in Western medicine, we're constantly focused on giving people a prescription, right? Most of these people are on an SSRI, an antidepressant medication. They're going to be on a benzodiazepine. They're going to, some of them even are going to be on things like beta blockers to reduce heart rate.
That's right.
And reduce some of those physiologic effects of their anxiety or their PTSD and what's happening there. So when we talk about cannabis, I like to talk about it in comparison to like what's really happening in Western medicine. How's cannabis better, worse? What is it doing? Yep. So let's talk about this patient that I have. We'll name her Evelyn. Okay. She's 62 years old. She came in to me with PTSD. She had witnessed an abusive situation with a child. So for her, her big symptoms are, she has a hard time falling asleep at night, has a hard time with night terrors. She has a hard time with certain social situations where there's adults and kids. Yeah. So she's been on Zoloft. She's been on some Xanax. She doesn't use that very much, but that's for the acute anxiety. Yep. And she has to take Ambien at night. So let's talk a little bit about cannabis with her. Yeah. Because with cannabis, there's going to be some specific goals. That's right. We're gonna talk about the connection between. Well, let's start there. Let's start at how somebody gets PTSD or how somebody gets these. It's like a negative feedback loop, right? Between the emotional center of the brain and the frontal lobe, the logic center of the brain, right? Is that?
Yeah. So I'm gonna go like a 30,000, maybe a million feet out for a second.
Okay, got it.
So life, okay? Mm-hmm. Life is the antithesis to entropy, right? Okay, so I'm getting all philosophical, but really, we spend energy in order to maintain order. And the natural state of energy is to move to a disordered state. So when we talk about this, we're talking about thermodynamics. We're talking about how we move energy. And eventually this is really, really important, because when we think about this, your body is always trying to reach this best energetic state where you're not spending too much energy to do something. This is homeostasis, right? What happens in our brains is that you will start to form these synaptic pathways, ways you think about things. And when you form these pathways, you will tend to have energy move down these same pathways because it's energetically more favorable to do it. Think about water moving down a path, right? And eventually you form these grooves and these, meandering rivers and so forth. And in some ways, thought processes work the same way. When you have a traumatic event, sometimes you form what's called a deep synaptic groove. Now, sometimes you can form these also with addictive behaviors. You can do this with opioids, where you form these deep, deep grooves that force energy to move down a certain path in the brain. When that happens, you will always be reinforcing that same thought pattern every single time. So in the case of Evelyn, she had this traumatic experience where she sees adults abusing a child or something along those lines, and this has formed a path in her brain that whenever that situation is presenting itself, immediately it goes to that trauma place, and that's where her thoughts reside. And that's caused a deep anxiety. It's affecting sleep. Of course it's affecting sleep, right? And of course it's affecting anxiety reactions, post-traumatic stress, and all of these various things.
Yeah, she avoids these situations.
She avoids them,
which is why we give her, now, behavioral therapy would be ideal to combine with this. But again, behavioral therapy is something that people don't have a lot of access to in the US. We tend to just want to go to the medication, to the medication. So I think we just, throughout this, we need to understand that behavior therapy in this is always going to be important, regardless of what medications or cannabis that you use.
That's right.
But these are reinforced pathways. Every time she sees something, she just automatically goes there.
Immediately her brain will go that way. That's absolutely right.
That's PTSD.
I mean, and this is how we think about addictive behaviors in general, right? And this is why, I don't know, let's just say pornography, for example. Let's say you became addicted to pornography. Even if you're in math class, all of a sudden, even when you're doing math, you're now forcing your brain to move down this pornography pathway that you've created in your head energetically, and so you're reinforcing that addiction, even doing other activities.
It's the same thing.
And that's for, you know, this is not a moral discussion. It's not about what's good and what's not bad. This is simply just energy movement, right?
Right. Smokers do the same thing. They'll come in and they'll talk about how I've quit cold turkey, I've used Chantix, I've used the patch, I've used the gum, and I'm just a smoker. And this narrative they tell themselves, this reinforcement, that's what's hard. So now, what's interesting about this pathway is it's modulated by the endocannabinoid system.
Yes.
Right? Like, surprise, surprise. These are receptors that are cannabis receptors in the brain.
Right. So this, back to, can cannabis help with this? And the answer is absolutely it can. And so when we think about, your brain has a reward system, and it also has a tendency to try and avoid pain. It has a tendency to try and avoid the things that have traumatized us, but it also wants to lean towards things that it rewards you with. Eating a piece of chocolate, stimulating your dopamine centers, right? And since THC basically will mimic dopamine centers, dopamine reception, you can reward your brain for going into situations that would normally cause you anxiety and reroute that pathway. Now, having said that, you can't just smoke before you go to the birthday party and now you're good. It comes back to this behavioral therapy. We work on how we think about this. We think about our breathing. We think about being in the now. We think about how we interact with the environment around us. We get some skills how to cope with this. And we reward ourselves for doing that by stimulating dopamine using THC. And now I've rewarded myself for being in a situation that was previously traumatic. Now, so you need a doctor to be part of that process.
Okay, so there's some goals with this treatment, right? We can get really specific about these goals. The first thing we want to talk about is this pharmacokinetics, this how does cannabis soften those pathways. I'd like just call it soften because they're hardened channels. It just makes sense to me to soften those pathways. This is chemistry in the brain. We're using cannabis to soften those pathways. The second thing we're doing is we're going to reinforce new narratives, new thought patterns with the behavioral therapy so we can reinforce the positive effect. We're going to decrease negative thoughts, and we can talk about dreams, decreasing negative dreams. And then fourth, we should be deprescribing other medications.
That's right.
I think that a lot of people come to us with this idea, hey, I'm taking Ambien, Xanax, and Zoloft, I've been taking them for 10 years. That's how long Evelyn came to me. She's like, I've been on the same dose, same thing for 10 years. It doesn't seem like that's why I got on those medications.
Right.
I want to move forward with my health,
especially
not just stay there.
Yeah, that's exactly right. When we think about medicine and we're trying to heal people, it's not simply this idea of like, okay, well, I guess you're on blood pressure medication your whole life. Now, maybe you should be, depending on what the situation is, right? But also, like in my case, I like chili cheese fries. They're just awesome, right? It's hard to stop.
You deserve them.
I deserve them so much. But having said that, right, if that's helping to cause obesity, it's helping to cause the salts are increasing my blood pressure, I'm not as fit as I need to be, whole medicine would be, okay, it's more fruits and vegetables, exercise, all of these other things, and then maybe I need a little additional help with a medication.
Right.
It's not simply, okay, look, you just keep on eating 30 pounds of chili cheese fries, here's some medication, you're good to go. It's not really the way to think about whole medicine. And when we think about medical marijuana and plant therapies, we're talking about actually trying to fix problems and actually get you away from having to be dependent on anything.
Yes.
And then
that's the key.
That's the idea. And so, and again, this is medical. We're not talking about recreational. Recreational people do all kinds of things to have stimulation. But this is from a medical perspective. We're trying to heal something. We're trying to fix this idea, right? And so, in the case of inflammation, that's a lot easier than PTSD.
Yeah.
Right? Inflammation, we know the things that are causing the inflammation. If we can actually chemically cause that to decrease, we win. PTSD has a lot of these other things, reinforcing behaviors, thermodynamics, pushing energy in a certain way in the brain and thought patterns. You have to rewrite this. And here's the thing that's interesting. In order to do that, it requires energy to do that, right? To change your behavior process, it requires a lot of energy. I think it's important to talk about pharmacokinetics because this term gets thrown out a lot, especially I hear this a lot from individuals who don't fully understand what pharmacokinetics actually is. So when we start talking about pharmacokinetics, we should be talking about really starting with ADME, okay? So this is absorption, and this is talking about how you absorb your medication. So in the case of a vape cart, we're absorbing through our lungs. Right?
Direct to the blood.
Direct to the blood, right? If I take a tincture, we're absorbing underneath our tongue through the soft palate, getting directly into the blood, but then we're swallowing and then we're also metabolizing through that way, right? If I'm taking edible, it's going to go through my entire GI tract, absorption, how we're moving across membranes. And this becomes really important when we start thinking about the actual dosing around creating a medicine for somebody and the mechanism that we're going to be doing it. Okay, so this one is distribution. Okay.
Pretty good. I think you got it.
I got it, right? I'm a terrible speller. We all have weaknesses. I can't spell. But distribution, where is that moving in your body? Or is it passing the blood-brain barrier? Is it concentrated in my liver? Where am I getting this drug distributed? And this becomes really important when we start talking about SSRIs and some of these other things, because we're actually depositing a lot of this and it's being stored in fat cells. And so you build up these half-lives, or you build up these chemical reservoirs in your system that even after I'm done taking this medication for weeks, I'm still having side effects from those medications because we're still getting, release over time from these other cells. Right? And so how you distribute the molecule becomes important. This is also really important with cannabis because we've talked about this before, but we talk about Q log P value. We talk about the ability of a cannabinoid to move across a membrane and so forth. And so how does that distribute? Well, in the cannabis, we have endocannabinoid receptor system 1 and we have endocannabinoid receptor system 2. So we're getting pretty wide distribution across almost anywhere where you have nerve cells. Especially for endo 1, and then we have certain organs and certain other cell membranes that seem to be targeted by cannabis that have absorption sites for different cannabinoids. Then we have metabolism. How does your body take that cannabinoid or other drug and what does it do with it? How does it break it down? How does it change it? A lot of drugs that are created by pharmaceutical companies have to go through the liver prior to actually being a useful compound. And so how do we metabolize and move that drug out? Because what ends up happening over time is this is where you'll block a liver pathway. It goes through P450, or
interacts with different medications. This is the interaction with the SSRI medications.
That's right.
The benzos that we're taking, and other systems of the body through the metabolism.
That's right. We're going to be doing something with these molecules. And then, of course, excretion. How do we get rid of it? You know? And so one of the things you end up doing when you're doing animal models is you will collect urine and feces and see if the drug that you gave them comes out in one of those processes. And so, so when we think about pharmacokinetics, this is one part of it. The other part we're talking about is half-life, how long the molecule is in the system. We talk about blood or plasma concentrations. So, for example, when we think about like sativa, for example, typically your sativa effects are pretty quick and they will wear off in a couple hours. Whereas an indica type strain typically lasts longer, but it onsets over more period of time as well. Mm-hmm. So if you look at like a bone regrower or something that helps with that, you look like at a Boniva or something along those lines, it could last a month. And it all has to do with, and then what's the blood concentration level, what's a therapeutic dose, what's a not a therapeutic dose. Because when we look at like CBD, unless if you're an average size or a typical sized person, unless it's 25 milligrams, it's not doing anything.
Sure.
Right? And so when we think about the pharmacokinetics, when I worked in pharma, this is the way that we would actually do it. We would administer a drug to somebody, and when I say drug, I'm talking about it could be anything from benzodiazepine to, in this case, it's cannabis or whatever it is. We actually take blood, and then we also take plasma, we take urine, we take fecal matter, whatever that looks like, and then we test it at intervals. So we take blood from this animal over long periods of time, and we watch those blood concentrations. And so then that tells us how long that drug is going to maintain in the system based on how much we've put in, right?
Sure.
And then we should be able to collect all the metabolites back out, and that's either through the urine or something. And if you have a loss, you put in 20 and you've only excreted 15, where are those other 5 milligrams?
Sure.
Right? And so this is where you start looking at organs, and this is where are we depositing into fat, cells. And if it affects the brain, at some point we're going to take these, little animals' brains, and we're going to actually take them out. We're going to analyze them and see if we're depositing in the brain and having an effect in the blood-brain barrier, which is important for safety.
So when you talk about PTSD and you're trying to basically rewire some of these pathways, is there a dose of, you mentioned that THC is really important for this process. Is there a dose of THC? Because from experience models, we recommend that these doses are between 2.5 and 10 milligrams of THC. They're not really high doses of THC.
That's right.
Why then is this dose the right?
Right, that's a great question. So remember, you're trying to stimulate the reward system. You're not trying to overstimulate all of your dopamine receptors, right? Because if you stimulate all of them at the same time, you can actually have the opposite effect. You can start a fight or flight response. You can actually stimulate your sympathetic nervous system to start releasing your immune response. You'll start releasing epinephrine. You'll start having cortisol get released, and also
you're essentially having the same response that caused the anxiety and the PTSD in the first place.
That's absolutely right.
I really wanted to bring this up because when you talk about medical marijuana programs versus recreational programs or adult use programs, there's nobody to tell you this, right?
That's right.
People are reportedly using it for anxiety, but maybe using too much.
Yeah.
This is the reason why, the arguments that are made why Utah does not have anxiety as a qualifying condition. And it really is because of this biphasic response that people have with cannabis. if they're using the right amount, the just right dose, and Blake and I have talked about dosing in other videos, but if you're using the just right dose, which evidence says that that's between 2.5 and 10 milligrams of THC, some people get up into the 15 milligrams for social anxiety. They find that that might be the sweet spot that they feel a little bit more comfortable, going to that event and seeing those, trying not to avoid that behavior that caused them the anxiety or the trigger. So again, we're trying to soften that those brain pathways so that we can essentially rewire our own thinking with behavioral therapy, and we're trying to use the right dose so that we don't get overstimulated.
That's right. So, very crude drawing. But basically we have the middle and the tail end of a nerve cell, right? So this is the axon. You have action potential. So basically you have like potassium on one side, you have chlorine on this side of the membrane. And then what ends up happening based on a signal that happens over here, you'll move all of this across the membrane, these move out of the membrane, and that causes literally electricity and a wavelength. And based on the wavelength that ends up hitting this part of the nerve cell, you will start to release little neurotransmitters. Now in previous videos and things we've talked about this, maybe they're little triangles or little squares or different types of things that have receptor sites on this side, little triangle receptor sites, little square receptor sites. And so when this triangle ends up going into this triangle, it will set another signal through, and then that carries on throughout the rest of the central nervous system. So back to this point of overstimulating, right? So let's do this in terms of squares. Let's say squares simulate THC and dopamine, okay? In this particular case, we have 8 receptors. Now, obviously, there's going to be more. This isn't drawn to scale or accurate, but we have 8 receptors. So we have just a couple milligrams, okay? And a couple milligrams ends up filling up a couple of these receptor sites. So the strength of the signal that's going is equivalent essentially to the synopsis or the increase of these 4 additively sending a signal down the line.
Right, we give just enough. We do this in medicine, right?
Right.
We give you X milligrams of the Xanax.
That's right.
Because X milligrams tends to work and doesn't kill you by making you stop breathing.
That's right. So the pharmacokinetics of this is simply this. We find the right dose that has an effect, the desired effect that we want. We test whether there's toxic events, what your blood plasma levels are, the half-life, and this is how we learn how to dose medications. But in this particular case, what if instead of this, we ended up putting so much dopamine into the system, you fill every one of these little receptor sites, every single one of them, and you still have tons of this left, and it's bouncing around, hitting these walls across the synapse and so forth. You send a very strong signal, but all of a sudden you're overwhelmed. And your body, when that happens, starts to have a negative response. It starts to have a fight or flight response because you've overstimulated the system. And so this is not a wreck thing that happens at this point. This is now, I'm having a panic attack. I think I'm dying. Now let's be clear. There's not any evidence that I have found that show that people have overdosed on weed and people are dying from it. I've not seen data to suggest that. But I know a lot of people who have overdosed and thought that they were dying, and it's simply because they have way more in their system than they have receptor sites, right? So in the case of Evelyn, if she were to dose really high amounts of THC, she would have a negative fight or flight response based on that, instead of having a positive interaction where it now softens, okay, that kind of hard wiring of the way she thinks about it. The other thing that makes this super important when we think about it is, okay, well, I'm a chronic user. I use like a lot all the time. Eventually, if you have this much floating around in the synapse, your body will start stimulating itself to create more receptor sites. So what happens is all of a sudden look, I use a lot of this, so now I'm going to hit a Delta 8 product. Delta 8 does not hit and bind as strongly as Delta 9, and I've just cut a lot of this in half, right? It goes in and then releases very quickly and gets absorbed cellularly. Am I going?
Yeah, no.
No, you're not going to feel it. And so this is why a lot of times you have to go through these washout periods if you're habitually hitting really strong concentrates, because if you hit them all the time, you eventually need more and more and more to feel the same level of stimulation, and it has to do with your ability to receive the amount of medication per receptor site.
Got it.
Does that make sense?
Yes. Now, tell me how we often, with, again, like the 62-year-old woman who's new to cannabis, wants to get off other medications, say she overdoses a little bit, gets that anxiety response from trying to build up tolerance to the medication. And let me explain that a little bit. So when somebody comes into us that's new to cannabis, there's a lot of discussion about how to find your dosing. We talk a lot about low THC dosing because this is really the pathway that really helps people from a medical standpoint. And it makes them feel better too, right? We're looking to feel better. And cannabis is very good at that, like in all kinds of dose ranges.
That's right.
But then we have to do two things. We have to start the process, and we have to build up a little tolerance to the side effects.
That's right.
Because if we need 7.5 milligrams or 10 milligrams of THC, that might get me high every single time I'm a little uncomfortable. So I need to build up a little tolerance to the side effects so that I'm okay.
Yep.
I feel more clear-headed. But in the beginning, is there a way, we often just say, well, just add CBD, but is that the way to kind of counteract that? How does CBD, better question, how does CBD fit into this discussion with mental health?
Right.
And the anxiety and the PTSD.
Yeah, so back to the board. Okay.
I love the board.
Thanks.
I mean, it makes sense when you draw just enough receptor sites and tons of stimulation, right chemicals, then it makes sense, I think, for people.
So we're back to funky nerve cell here, okay, and we're going to release neurotransmitters onto this side. When we start talking about like SSRIs and a bunch of really strong other compounds, we look at, benzodiazepine, we look at Klonopin, and we start looking at these. Those are specifically designed to shunt areas so you cannot get transmission going. And that makes it so you don't have stimulation. So in the case where if you're having overstimulation of fight or flight response, if you take a mood stabilizer, like a Wellbutrin or something like that, or a Zoloft even, to start to balance out how many are being released and then absorbed on the other side. So let's say I'm not an experienced cannabis user, okay? And then we'll talk about experienced cannabis users, but I'm not that experienced, so I don't have a lot of receptor sites, okay? Well, if I start throwing a lot of cannabis in here, it's really easy to quickly overwhelm that system and have a negative response. Yeah. So when I pair it with CBD, and we've talked a little bit about this before, again, this will be like THC, okay? CBD is sort of like a squishy ball that fits into a lot of these areas. In fact, there's a lot of evidence now that shows the CBD fits into the opioid receptors. It fits into tons of different receptors. And so even in the medical cannabis handbook for doctors, there's a diagram that now shows CBD fitting into a whole slew of different receptors. And the thing that's so important about that is that means, okay, so I get this stimulus from this one to this one, but instead of this one going in here and then starting to overwhelm, CBD has already occupied that spot. Am I getting the exact same reaction as this to this? No, because in order for this to send the signal at the right wavelength to get the full response, it needs to join and it needs to have that connection, like a lock and a key. So a lot of people describe this in locks and keys. It needs to go in and fit. CBD is like a skeleton key that doesn't fully turn the lock. And so by doing that, you're cutting down that whole response. And so So two things. One, pairing with CBD will often always downplay a negative response in the CNS because you're blocking some of those sites. The second point would be if you've overused, you can downregulate your negative response by, again, blocking some of your receptor sites so you're not being overwhelmed by whatever neurotransmitter it is.
This is kind of an ideal point to talk about Evelyn and how this patient, for example, kind of went through the process. So in the beginning, we started with 4 or 5 days of low dose tincture.
Yep.
We've talked about this before. Tincture is a good way to microdose, to take really low amounts, to have a specific dose, right? So we can start at 2 milligrams THC. It can all automatically be paired with a CBD at maybe 10 to 1 or 5 to 1. So with this patient, we started out with 2 milligrams every day in the afternoon for a few days, building up a little tolerance. She ended up using 7.5 to 10 milligrams of THC at night, which seemed to quell the dreams, was taken about an hour before bed to give it a chance to metabolize into the system.
Because some of it's going to hit really quickly under the tongue, right? Because you're going to absorb through that soft palate very, very quickly. But then a majority of that then is going to go through the stomach and intestines and have to absorb through the microvilli and then hit the liver. Right.
And that lasts 6 to 8 hours. So when she would wake up in the middle of the night, it was easier for her to go back to sleep because there wasn't that anxiety and the racing thoughts. They were kind of already calmed down. During the morning hours, she would microdose just a few drops, like 5 drops of the tincture, probably 2 milligrams of THC with a slug of CBD to kind of buffer. That seemed to reduce her. First, she got rid of her Ambien. That was kind of the low-hanging fruit, pretty easy to do. The second thing she ended up being able to stop was the SSRI. With the microdosing, she felt like that it took the edge off just enough that she didn't feel like she was getting a benefit from the SSRI.
Yeah.
The last thing, though, was the benzo.
Yeah.
Benzos are strong. And in her case, it was hard. Those social anxiety events were still hard, and so she was still using the benzo. So after a little while, we introduced an inhaled method, quicker distribution.
Yep.
Right through the lungs. It was able to mix with THC and CBD. Still, she kind of didn't like the mental part, that THC part.
Yep.
So we ended up moving to a strong CBD with a CBN, another cannabinoid that she was able to inhale, take about a 2-3 second inhalation, buffer, essentially use it as a buffer, and that seemed to work. Was it as good as the benzo? I don't know. She's, it's hard to say, but was she able to stop taking the other medication? Yes.
Yeah.
So pretty successful story.
It's a successful story because in the long run, benzo has a lot of side effects associated with it. And so, and let's be clear, benzo is going to shunt feeling. She can go into those situations because she's not feeling anything, whereas she will still be able to experience those situations on a cannabis or a cannabinoid, alternative.
Regimen. And that, that's interesting when you draw it up here. The benzos are really just shutting down, where cannabis is, it's not, CBD regulates things in the synapse, but it's not, but it doesn't shut anything down.
It doesn't shut anything. In fact, you get partial signaling from CBD, which is why CBD seems to, it helps me with my anxiety, it helps me with my sleep, it helps me with my pain, it helps me. Look, by itself, it's probably doing not tons of those things, but it's partially doing a lot.
A lot.
And so that's why when you pair it with other cannabinoids, you get this really heightened effect. And this is where we talk about entourage effect. If you're blocking certain neurotransmission, you get, all right, this is backing up a little bit, but you get this junk signaling that occurs all the time. We end up having signals from our brain. Every time I put my foot down, I'm sending signals to my brain about my foot, but it would be really annoying for my brain to sit and process my foot and my shoe all day long thinking about my foot in my shoe. So your brain, like, sort of, I'm not going to recognize that part of what's going on, but I go running and now I'm becoming very aware of my body and what I'm doing when I'm running and all those type of things. And so you get all this like signaling that happens all the time, right? And so what ends up happening is when you use CBD, you sort of shunt some, not shunting, but you sort of like stimulate, you're modulating a whole bunch of that junk signaling. And all of a sudden, now when you have a little bit more THC, THC actually works better because you're now heightening the response within those specific receptors without all this other data coming in. And so you will get partial relief from a whole bunch of things as a result of CBD. But by itself, will CBD take care of the anxiety? Probably not by itself. CBN specifically affects that pathway, so that's a really good answer to that. CBN may be the absolute right choice, and it sounds like in the case of Evelyn, it worked very well.
So this is, I mean, we can kind of wrap up our discussion tonight of the PTSD and the anxiety. You know, we'll do more videos on this. Watch our Discover Marijuana YouTube channel, subscribe and like, and now we can get on to some of the questions people have.
Yep.
Are you ready for that?
Yeah, absolutely.
We've got some help with the questions going to be pulled up.
I do want to say one thing. For somebody who's a chronic user and you feel like I just have to keep increasing my dose so for me to get the same effect, even if you're using it, you know, recreationally. Now we're here talking about the medical side, but there's obviously people who want to do this recreationally. It's the same thing when you start creating more alcohol dehydrogenase in your liver. I can put away a lot of alcohol. Okay, well, you just have more enzymatic activity that's occurring in the liver is what's going on. So that way you can process alcohol quicker, right? And so you can start to back that off and re-stimulate all of that process again, but it takes a little bit of a washout period, which doesn't mean you quit. It just means if you slowly break that off over a period of time, all of a sudden you don't need to hit the dab rig anymore in order to get the same high that you got 5 years ago when you would simply smoke flower. And so this is an important way to think, and this is one of the cool things about how cannabis works versus some of the drugs that we have created in Western medicine, is that your body will organically change based on what your dosing is coming in, because you already have a system to know what to do with cannabinoids, which is not the case for some of the other drugs that are created. And so if you don't like that you're having to spend so much money every single week, you can back that off, and then you will get the same effect that you had years before by starting to remove some of those receptors.
Now, we often recommend that starts with a 2-day cannabis fast, which is pretty hard for some people.
Yeah, I think we'll get to it a little bit later, but like headaches, right? If you're taking cannabis for headaches,
we talked about this before we started filming.
Yeah,
you get rebound headaches.
You get rebound headaches from using cannabis. So you're using it to fix your headache, but the cannabis itself is giving you a headache later.
Yeah.
In those cases, a fast is probably one of the only ways to deal with that. But I will say it's miserable. Anyone who's had caffeine headaches and you're addicted to caffeine, right?
It's kind of the same type of headache. Okay, so this is the first question we can answer. It's not up, but we'll answer the first question. That is, why when I smoke sativa, why when I use this sativa, it gives me this right-sided headache or this left-sided headache? We deal with this all the time in what we would call legacy users. People who use a lot of sativa, seems to be related to sativa terpenes or strains.
Yep.
Overuse, another good culprit. But we often recommend you switch to indica. In indica terpenes, indica strains tend to help. Drink lots of water and exercise tends to help.
Exercise will help metabolism in general. It speeds up metabolism for everything, whether it's chili cheese fries, caffeine, or cannabis.
Right. I love to kind of just go back to the old. You know what? You should be exercising more.
Yeah, I mean,
it works.
But it works. It works for a lot of reasons. And then water helps dilute, which is important, and it even happens at the cellular level. The more water you drink, you will have osmotic pressure amongst all your cells, and if you're dehydrated anywhere in the body, you will start to have imbalances, and you can dilute any of the effects that you have from a negative side by increasing osmotic pressure by drinking water, and it dilutes out everything else.
So back to the old school, do the normal things.
Do the normal things.
Don't use as much of the sativa. It can be high. It can be still from high THC levels, like straight THC. If we added other cannabinoids, potentially could help as well.
Should we talk about sativa versus indica real quick?
Sure.
Okay. This is probably really important, and I may be burned at the stake for saying some of this stuff. So please.
Okay, I'm ready. Okay. And I guess I'll get my torch.
Are you? Oh, come on now. So when we think about the differences between sativa and indica, what we're really talking about is the delta 9 itself chemically any different between sativa and indica?
No.
The answer is no. The delta 9 molecule itself is exactly the same. So what's the difference? What is this profile doing for me? We know that sativas typically are energetic, and we know that traditionally speaking, indicas are sort of relaxing. If I'm going to try and chill out, I would do an indica. So
yeah,
here's
some people use sativas for ADD.
Yeah, that's right. And so when we think about some of these things, we should be talking about the terpenes, because the terpenes are what's making the difference here. And because if we're looking at most strains, and let's all be honest, we're all friends here. I should go over to the camera and hug it. We're all friends. Look, almost every single plant that's out there right now is a hybrid. There's very few strains that are true sativas left, or very few true indicas that are left. Most have been bred specifically for certain terpene qualities or to increase THC in general. Now, there are some, for sure, but generally speaking, they're all hybrids. We've already established that they're all hybrids, so they're all mixed between sativa and indica anyway, and they all have the exact same delta 9 profile. So what's the difference? Is there a difference? And on the surface, people would be like, well, based on what you've said, there's no difference between them. Well, there is a huge difference. When you start looking at the light terpenes, now all plant-derived oils have light oils, medium chain oils, and heavy oils, okay? And so in the case of like hemp seed oil, there are no cannabinoids and it's a light oil, right? And so when you talk about cooking as well, you're talking about saturated fats, what oils are better, cooking oils and so forth. Light oils versus medium oils versus heavy oils. All oils have these different qualities. When you look at sativa typical terpenes, we're looking at citrulline. We're looking at alpha-pionine. We're looking at these lighter chain oils, which, by the way, help carry delta 9. So what that means is I will metabolize this much quicker than I would metabolize this combination. When you look at indicas, they're almost always myrcines, humulines, and some of these bigger, longer chain, heavier terpenes, which means I'm metabolizing it back to our conversation about ADME, right? Mm-hmm. It takes longer to metabolize this, so all of a sudden I'm getting this slow burn of delta 9 across all my receptors over time, which has a tendency to mellow you down versus stimulating all of them quickly as they're metabolizing quickly. And so when we think about when you go and talk to your pharmacists and so forth, and you say, look, I'm looking for an energetic, something that's like a sativa, you're looking for specific terpene profiles that will give you that effect. Right now, Zion has their sour Pinot carts.
Yeah.
Like the sour Pinot is, I think, at 85% delta 9, mm-hmm. and our cookie dog, I think, is at 86. Well, what's the difference between the sour Pinot and the cookie dog? Both were distilled, right? Mm-hmm. Both we took the plant material, but we also collected all of the terpenes from both of those strains, and we put the terpenes back into those carts. And guess what? The sour Pinot is more like a sativa because it's got citrulines and these energetic terpenes. And our cookie dog is more of a indica because it's got these heavier terpenes. And so people have told us, yeah, both of them at those concentrations, yeah, I'm having a really nice effect from these. Mm-hmm. But people are telling us this one seems to last longer, it seems to make me more mellow, whereas this one, I'm in for a ride.
Right.
And that's what we're hearing, at least. And so, yeah, that completely makes sense to me. Right. But it's not because my Delta 9's that different. The Delta 9's exactly
no, it's
the
almost
same.
the same.
Right. It's because of the terpene associated. So that becomes really important how we think about it.
Yeah, so when you're going to look for your medicine at the pharmacies, I mean, this is really what the difference is between the two. Okay, so next question. Mental health question. Does cannabis help bipolar disorder? And I think you're going to find all of these questions are going to be, it depends.
Right.
And so we can bypass that portion. But bipolar, really controversial topic in cannabis medicine, because there's some evidence to support increased incidence of bipolar and psychiatric disorders with heavy use, especially with younger people.
Yes.
Right? If you're starting to use this as a teenager, you have an increased likelihood of developing these types of disorders, bipolar being one, schizophrenia being another. However, the 2017 report from the government and all the scientists said chronic schizophrenics, chronic bipolar people who already are using cannabis tend to get a benefit.
Yeah, that's right.
So this is probably why it's not on the list of approved conditions. If you had it and you were already using cannabis, probably something the Compassionate Use Board, I would suspect, would be open to.
Yeah, I mean, so this is the way that I would think about this. If you're starting off and you're a kid and you haven't fully developed all of your normal neuro pathways, taking any medication that's going to alter the development of whatever your normal is, and we all have differences, right? I mean, some things work good for some people, and that doesn't mean it will necessarily not fix it, but if you're taking things that are going to adjust the way of whatever your typical is, there's always a danger with doing that, because that's kind of a road that's hard to come back from, right? And so if you start heavy drug use, especially when you're young before you develop stuff, you have thermodynamically forced yourself down a pathway that is nearly impossible to come back from. So that's always my first thing. And this is why we have a doctor here, because if I ever just am speaking out of turn, correct me. But that's been my experience. Having said that, however, typically people who have psychiatric disorders have a lot of things that require synaptic input. You will have rituals, you will have tics, you'll have something associated with whatever that is. Not always, but that's often the case. You know, in obsessive compulsive disorder, I have to turn around 3 times before I go through a door, or I will sit and I will put my hand and I'll do this 5 times before I can talk to you, or whatever that is. Or there's some people who will, you know, just sit and move their fingers, and they need some kind of stimulus and input. And what we have found, at least initially, is that what cannabis does in those situations is it's providing a dopamine stimulus so that you don't have to have the other synaptic inputs in order to have this balance.
You're already stimulating the receptor, so you don't need to do the repetitive movements.
Yep.
And that's really interesting, because that goes across a wide array of behavioral, what we would consider behavioral disorders that affect both kids but adults too, and can be something that you could potentially treat, you know, with daytime use, right?
Absolutely.
Because you got to go to the office, you got to interact with people,
and this is where like a Delta 8 may be an appropriate molecule for that, right? Or a tincture or something that's long lasting. Would I give my 9-year-old with Tourette's massive amounts of cannabis? Well, Dr. Tim, I will leave you to make that determination.
We deal with the kids once in a while. A lot of people, we've kind of ended up being the default place they send the kids, right? Because we pay attention, we know a little bit about this, and we usually always start our young patients off with a regimen of CBDs, other cannabinoids that are non-psychoactive.
Yep.
We test that, and we really work with their primary care providers, their neurologists, to help with that before going to something like THC.
Right.
I'm not saying it's off the table in every case, but certainly you want to go down.
You just want to be really cognizant.
Yeah, you want to be really careful.
Yeah. The last thing I'll just say about that too is that, yeah, so the 9-year-old with Tourette's, maybe not. In a case of where somebody's having like extreme seizures, and the extreme seizures are causing things like literally cooking parts of their brain, look, THC may be way more appropriate in those cases because it's going to be better to overstimulate the dopamine receptors in that case than actually having the seizure.
Right.
And so this is where you have to work with your medical professional and your care team, quite frankly, to get the right course of action. And I don't recommend anyone ever doing it by themselves.
No.
Work with your care team.
The next question is, what is the benefit of microdosing? I love microdosing as a concept because it doesn't have to be psychoactive. The benefits of microdosing are, this doesn't have to be psychoactive. I don't have to be stoned. I don't have to be high. I can use something that's taking the edge off. I can use something that is stimulating the body's own healing. Have you, you've looked at these models where they give animals small amounts of cannabinoids like THC, CBD, and the system itself is working better.
Yeah.
And things are healing on their own with microdosing.
Yep.
And they're not getting any mental effects.
This is where microdosing is also extremely interesting when you start thinking about topicals, right? How come it fixes my rash? Or I put it on my burn and my burn goes away within a day or two. I mean, we literally have cases where we've seen people who have burns that they do the, various topicals and the burn literally goes away in a couple days. Like, how is this even possible? And the system seems to do better being regulated that way. The one challenge I have as a scientist around microdosing is this. Everything ultimately in the body comes back to this idea of milligrams and how much your body can use to do something effective with that. Think about it like a pile of vitamins. Your body needs X amount of certain types of vitamins to do normal functioning, right? If it's too small, you're not quite regulated the way you need to be. If it's too many, your body can't do anything with the excess either.
Yeah.
So what is the effective dose in milligrams to get a desired effect? And that is the trick of microdosing, is that if you're doing it right, you know exactly how many milligrams you're getting.
Yeah.
If you're not doing it where you're actually measuring how much you're getting, oh, I did a little microdose of this. Well, what does that mean? I sort of did a half inhale here and then I did this and that, like that.
What you're saying is it's essentially not, if you're getting therapeutic effect, you're essentially not microdosing, you're dosing.
You're dosing.
You're
That's exactly right. Thank you.
You're dosing.
That was a much better way to think about it.
Right. Okay. That does make sense. And in that respect, I mean, I agree. You're essentially not microdosing. If you're getting a positive effect, you're just dosing you're just low dosing.
Right. That's right.
That's just your dose. Okay. I like it because I think when you talk about Utah specifically and you're talking about a religious culture, microdosing, that concept of using less, I don't have to get high again, I don't have to be stoned, but I can get some therapeutic effect and reduce my other medication use. That seems like a win-win.
Yeah, it definitely appeals, I think, to the culture here.
Okay, what if my job tests? Does my card protect me? No. Your company writes their own policy with medical cannabis. You should, if you have questions about this type of thing, then you need an attorney. But
we are not attorneys.
Yeah, we are not attorneys.
We are not attorneys.
But we will tell you that the company writes their own policy. If you read the statute and you are a state employee, firefighter, police officer, teacher in Utah, you work for a state entity, then you are protected by the statute. But if you work for, Delta Airlines or something,
or
and they
the
have
Fed,
a policy, or the Fed, you're out.
Yep.
No THC at all. Okay, when will growing be available in Utah? Good question. Question we get a lot.
Yeah.
Totally, Blake and I are guessing on this one. I'm going to guess 5 years. But that's just a guess because I think you have to saturate the market. Everybody has to recover their kind of costs.
Look,
what do you think?
I'm just going to throw this out here. We're in Utah. Everyone keeps saying to me, I can't wait till this nationally goes legal. I can't wait for this to be nationally legal. Look, I'm going to be the bearer of bad news probably. Utah regulates its own alcohol laws. The Fed, when they release this, and this is my opinion, I think when the Fed finally deschedules and everything else, I think the Fed will leave it up to states to create their own rules around cannabis.
Well, and we've both read the statute. The statute does not allow us, even if it was decriminalized, the statute does not allow you to purchase cannabis outside the state and bring it in, period. Even if it's legal.
Even if it's legal everywhere else.
Everywhere else.
And so that means we have to change in Utah legislation our own individual state laws to recognize what's going on federally. Now, does that mean Utah would prosecute? Look, I'm not going to venture into any of that. I don't know. You can go talk to the AG.
So
but what I will say is, back to the growing of your own plants, I don't see Utah approving that anytime soon. I just don't see it. And so,
how do you feel like this is our next question, and this is price. It's always comes down to price. How do we lower the price of the entire process? And the question I get, we cost, if you come see us, usually the cost is $250 to have the evaluation. That includes a 90-day follow-up.
Yeah.
All of that's inclusive, and that's expensive. It's about the same as going to a specialist with your insurance.
Yeah.
And a follow-up, definitely. In fact, it's less than 2 visits with a specialist from an insurance standpoint, but still this is out of pocket. Then you have to pay the state $15. Then you have to go buy an $85, $90, 1 gram vape cart.
Or 110, depending on what vape cart you're getting.
So how does that process over time, how do you see that? How do we get that cost down?
I have a lot of answers to this, and most of them will not be popular probably with most of my peers. Right now, prices are mostly being dictated, well, let's call 3 things. 1, the state has fees that have to be made up for by everybody. So a license is $100,000, you pay that annually. There's fees for the software necessary to track it. So you have to buy a license on that. That's going to be $3,500 with $250. You don't need to worry about any of that. That's just cost to do business. So the state's never going to relinquish those. So there will always have to be a certain amount of money that is made to cover that. Because if you can't cover that, there's no reason to be in business, period. Right. The second thing is we talk about federal taxing. Even though it's federally illegal, you still get taxed. And the code that they use is called 280E. And basically, we'll do a little economics lesson. Basically,
and if you want to know a little more about 280E, we did a podcast and we talked to Jeremy Sumerix with Deseret Wellness, and he had a really good explanation of 280E and the retail side, what they do. Utah in the Weeds is the podcast, and I would recommend going and finding that episode because he does a really good job.
He'll do a better job than I will
of describing that.
The basic gist is this: when you have a business and you have expenses, there are certain things that you can write off that are what's called above the line versus below the line. Yep. In a normal business, I'm making widgets and I'm selling widgets. All what I'm paying my employees, all the costs of my packaging, all the costs of the boxes that they come in, the costs for health insurance, the cost for all of those things. Those are all things that I can take a write-off on in my taxes. With 280E, I can't write any of that off. And so I'm actually much higher, and they call it COGS, right? Which is the cost of goods sale.
Your cost is higher.
My cost is so much higher because I can't write off any of these other things. So that means that every single time anyone grows, anytime, and then they sell that to a pharmacy, and anytime the pharmacy sells to you, they're going to pay a higher taxes on that than they would for any other cost of goods sold.
So the bottom line could be, look, we have all of these things we're dealing with, regulation, and this is new. I still think the supply, once you get everybody up and running, which still hasn't really happened.
It's not happened.
It's not even close, right?
It's not even close. So again, back to the first point we had, I can't do anything about the state things. I have to make at least money to cover that.
There's going to be fees. That's going to make it expensive probably all the time.
I have to make, well, no, I'll say it doesn't have to be as expensive as it is, and this is where I'm going to get hanged by my peers. But, and then you have this whole other side where I have to account for the 280E. I'm going to have to pay more taxes. So I at least have to make enough money to also now cover that. Because if I can't cover that, again, there's no reason to be in business. So there's at least two things there that I have to be able to cover. Now what dictates price? And honestly, in the state of Utah right now, what's dictating price are the pharmacies. And the pharmacies are dictating their prices based on a whole number of reasons. Some of those are supply versus demand. If the demand is greater than supply, the price goes up. So to your point, if all of a sudden everybody is growing what we should be growing, and all the producers are producing as much as we can produce, and all of that is inside all the pharmacies, prices should drop because the supply and demand will start to even out, and so people will be able to, they should be able to lower those prices. But you know, as a cultivator, I can charge way more to a pharmacy than I could in any of our surrounding states because the demand is so much higher than the supply. Now, from my perspective at Zion, we try to think about this a little bit differently. So we don't think about this in a typical, and this is not to say that others don't think this way. I'm just telling you what Zion's philosophy is. We think that this is a medical program for patients. I don't have access directly to the consumer without a pharmacy. I just don't have that. We sell all of our goods, every one of our goods, to a pharmacy at wholesale prices. And so we do that at certain rates. The pharmacy then determines what is their necessary recoup to pay for that, okay? And so there's this weird balance that occurs. And that weird balance is, how do we make all of this happen? What I can tell you is prices will drop. They will drop over time when that supply-demand ratio comes back. And I'm hoping at some point, you know, if Zion can get access to direct customers, we're going to try and lower prices that way too.
Sure. So if we don't get to your question in the time we have left, we'll answer all of the questions in the next few days as we go along. So don't.
Makes sense.
Okay, so with the controlled substance database inclusion, can I be a patient and have a gun? So let me explain a little bit about the controlled substance database inclusion. The Utah legislature added to the law that we will, as patients, all of our data will be added to the controlled substance database. This is a database that has really, in my opinion, two main uses. One, providers like myself can go onto that. If I'm going to treat a patient, I can look at that database. I can see if that patient is getting any other controlled substance from another provider or another prescriber. It's important. It's designed to be used so that I can make sure that a patient isn't manipulating the situation and getting opioids or benzos from multiple providers. It's also designed so that we can be a part of the whole healthcare team.
That's right.
And we can have this, this accountability on both sides, so that as a provider, I'm not prescribing to just Percocet to everybody.
That's right.
Because I literally, when I prescribe a controlled substance and they're flagged, I get something at my house. I get a letter mailed to my house about that patient and their prescription. So I know if I'm the one doing all the prescribing, my name is going to be out there on all these prescriptions. So it kind of is a good balance.
Yep.
That's why it's designed. The second thing it does is it gives access to universities and these data analysts to do research on the cannabis use and the opioid use. And specifically, I would think that would be the big thing that it's going to do. It's because we're going to have access to both the opioids, the benzos, and the cannabis. We can now look at across the board, is opioid use going down as cannabis use goes up? And how do we like report that?
So I would say that doctors treat individuals, epidemiologists treat populations, and they do that through data. Now, all of the things that we're saying is best case scenario, okay? Could systems be used for evil, nefarious purposes? Maybe. I don't think that's generally the case. If you think that everybody is always out to get you, you may be dipping too hard into the product. But that doesn't mean that everything is always honky-dory and flowers either.
No,
but
because I have seen personally the controlled substance database be used to discriminate against patients, specifically for treatment.
That's
and that's not how it's designed, and that was
it's
my
not
concern
how it's designed
with this legislation.
Yeah, and so back to Tim's point, all things being equal, the reason to do some of these things is, as an epidemiologist, there's all these rules that we have to follow to start conducting studies. And so your name's not going to be showing up on some study somewhere that says this person's doing this thing.
No.
But that data can be compiled, and we can run a retroactive study about use and comparative to other drugs. And to your point, we can see opioid use drop with the use of cannabis, which starts to give a strong argument that says, look, that's a condition that probably should be a qualifying condition because we actually see benefits from it. We see, drops in anti-epileptic drugs.
You could see drops in Adderall. You could see drops in benzos. Okay, but we got to get to the question. Really was guns, and we kind of got off topic.
Yeah,
but the answer to your question, and you can own a gun. Look, if you're going to go buy a gun from Cabela's and you have a cannabis card, you have to answer the ATF form, and that form is a federal form. And again, not a lawyer, but I know about the form. You're going to have to answer this question. The question is, do you do an illegal substance? And federally, the answer is yes. State law, the answer is no. So if you're going to go to a licensed gun seller and buy a gun, you're going to have to either lie on that form, that's a federal crime, or you're going to have to tell the truth and not buy the gun. If you buy the gun from a private seller, you don't have to fill out the form.
That's correct.
And then you can make that decision. Are you going to get your gun taken away? I get that question all the time.
No one's going to take your gun away.
No one's going to take your gun away.
Yeah.
Okay, what's the next? Let's pull up the next question. If I want a medical card in Utah, how would I do it?
You're like the best guy to talk to.
UtahMarijuana.org. Search Utah marijuana card. Look up a bunch of people. I'll get on my soapbox and I'll say this. I think you should choose a provider who knows what the heck they're talking about when it comes to cannabis medicine.
Absolutely.
Who pays attention to what's going on with the research, even just a little. If you want to keep your costs down and you have a provider that's your primary care provider, you've had that relationship for a long time and they are willing to do it, then you can save money and you can do it that way. If you want to get a specialist involved, and I think for a while there needs to be, this is my opinion, for a while there needs to be cannabis specialists in medicine because we didn't get taught about it in school.
That's right.
And it's a complicated medicine.
We
talked about all this biphasic. If you take a little, you can get a good effect. If you take a lot, you might not. What cannabinoids can you add? We specifically focus on deprescribing other medications that are just used to get symptoms. But you meet with a provider who's a qualified medical provider. You register with the state, the EVS system. You pay your fees to the state. The provider does their recommendation in that system, and they'll email you a card. Then you meet with a pharmacist, typically. You don't have to, depending on the law. There's a little detail on that. And you can find out more about this at UtahMarijuana.org. You can read a couple of articles. We have articles on how to get a card, what to look for. We have frequently asked questions about the program. We have my first 2 years as a cannabis patient in Utah, what that looks like. So you can just have all the resources that you need to get this set.
And if you're a provider or you have a personal provider who has a lot of questions about cannabinoids and how that works, you can reach out to me at Zion, and I'm happy to start talking about how cannabis works and all the stuff that we talk about together. I'm happy to start educating on that stuff for them.
And that's really helpful. You've been a huge resource to us, my clinic staff, and I think providers in the state, patients in the state too. Okay, what is it in cannabis that gives you anxiety? How do you fix that? We talked a little bit about that before. Yeah. Is it just the THC? that gives you anxiety? Is it just the dose?
So this is the biggest thing. THC is usually the culprit, mostly because THC is one of the few cannabinoids that you feel. So in the case of like CBD and CBG and CBN, you can take them and have a beneficial effect, but it's not like you feel like $1,000,000, right? So I took a whole bunch of CBD and with CBG, and the inflammation in my shoulder goes away, and it's not like all of a sudden I'm doing cartwheels, but the difference is I've raised my arm above my head and now it doesn't hurt. Mm-hmm. And so it's more of like the lack of feeling around that more than it is feeling something. So what happens is if you overstimulate with other cannabinoids, typically what happens is you get tired. You end up having lethargy. And usually if you've taken a bunch of CBD and then you feel lethargic, that's a good indicator that you've overdosed on the CBD. Is it dangerous? No, but it means you're going to have to sleep it off, right? The difference is with THC is you feel when you've had THC, you feel high. Yeah. And so when you feel high, all of a sudden, if you've overdosed THC, typically you'll start having an anxiety response to that. And that's really what that is.
Cool. Oh, what causes short-term memory loss with cannabis? This is a great one. Now I understand it. Tell me if I'm wrong. I understand it that the place we perceive time, the place we perceive like short-term memory, has a lot to do with how THC is affecting us.
Yes.
Is that the simple version?
That's probably the greatest simple version. So, real briefly,
is this really the time and short-term memory? Can we put those two together?
Yeah. Like a lot of people experience time dilation and things like that when they're on weed, and I'm in the moment and I see everything more clearly for a time, right? All of that.
It does both, right? On the one hand, you have this warped sense of time, but on the other hand, you're really in the present. People describe being in the present.
Right. So
but that's that same concept on its head.
Here's my terrible nerves and synapse again. Okay, so this is your synapse. All memory that you have lives inside this synapse. And you have these wall cell membranes, right? That when a neurotransmitter hits some of these, it stimulates a memory. Okay. So what happens if I've already stimulated this nerve to have a certain wavelength, and I've stimulated this nerve so that the whole thing is constantly fired? Remember how earlier we talked about this action potential, and that creates electricity in the nerve cell, and it moves across and releases certain neurotransmitters? If this nerve cell has already fired, at some point it's going to have to reactivate and have this action potential reset. Mm-hmm. Okay. If I've overstimulated or stimulate dopamine too much all the time, even if I have a neurotransmitter brushing these walls to stimulate memory, there's no way for me to generate action potential to actually have the memory and think, because I've already sent a signal off and I haven't reset yet. And so all of a sudden, if you're in this time dilated mode where I'm hyper aware of everything that's happening now, I'm fully stimulating now, but I have a hard time going back and remembering that state because I've overstimulated the neuron. The now. Right. And so I can't go back. And so the way we perceive time is often the distance or the time necessary for neurotransmitters to move across this 20 nanometer gap between these cells and how they're hitting each side of this to stimulate memory function. It's really complex. And even if you're an expert at this...
this is blowing my mind right now, because what I'm getting is the memory problem with cannabis is because I'm overstimulating the now, and therefore I can't stimulate the past.
That's right.
Remember that.
That's your guru message for today. We should be talking to some yogis about this.
Welcome to Tim and Blake. We've got about 10 minutes left, but That's it right there. You know?
That's it. That should be the stamp.
That should be the stamp.
You can't appreciate the past if you overstimulate the now.
You cannot appreciate the past if you overstimulate the now. Way to go, Blake.
Thanks.
Okay, maybe some not as exciting questions. Can I use cannabis while pregnant or breastfeeding? Okay, in Utah law, no. Hard no. No breastfeeding, no pregnancy, period. Now, we've had patients that have come in, they've been on multiple medications for nausea during pregnancy. They find the 5 milligram gummy helps. We have, because this is the law, we have recommended they do not use cannabis, and it's really try not to manipulate that system. Now we refer them to an obstetrician, and they can help make that determination on what is safe and what is not. That's the bottom line. You need a specialist in that child.
Yeah.
And there's differing opinions about this in other states and other.
So from a scientific perspective, if you can pass the blood-brain barrier, you're going to be able to pass the placenta barrier.
Yes.
You will be able to influence your child by having cannabis and cannabinoids. So if you are used to being a cannabis user and you're not taking it medically, right, my immediate gut reaction, this is just my opinion, you know, and this goes back to exercise and sleep and good food. You probably don't want to ingest anything that can affect, you know, the fetus at that point. And that would include large amounts of caffeine. That would include, you know, almost anything that's considered a stimulant that move across the blood-brain barrier. Having said all that, I think about this a lot like I think about seizures. If you're having postpartum depression. Now, I'm not the expert. Don't come to me and ask me. I'm going to send you to Tim, who will send you to an expert.
Yes,
right? I mean, that's how that will work.
Right.
But
I can manage the cannabis part, but
if you're using cannabis to say help with depression, and your depression is so bad that it endangers the child, there may be, and you want to use cannabis instead of some other really harsh SSRI, then or some other major
other class D
then maybe there
risk
might
to
be
the fetus.
be a reason you might do that.
This is someplace where we need more research.
We need a lot more research on this.
In the safety and efficacy of this compared to, and specifically, the research that we're missing in cannabis is more, in my opinion, it is more related to the comparison of the current drug or the current therapy we're using, the Zofran, the Phenergan, and the cannabis. We need to compare those three together. We need to see which ones are causing the worst side effects compared to the others. Because right now, we don't know enough about the cannabis in comparison to the medications, and those studies haven't been done.
And this is why I rely on science on this one and say just what the effect is. We do know what the mechanism of action is. It is not my job ever to tell somebody what they should or shouldn't do with their own bodies and what they do with their own lives. That's strictly every individual's choice. But from a science perspective, we know it passes the blood-brain barrier, and that's challenging.
Okay. Where can I find a CBN strain? Well, I mean, I know you can get our friend Kyle Egbert, right? He'll make a vape cart with X amount of CBD, X amount of CBN, X amount of CBG, and label it, and you can buy it.
Yep.
So I guess you could do that, and then you could mix it with something that was with THC.
Yeah,
we find that a lot more people are doing that.
Yep.
Because the growers are so busy producing medical flower, medical grade stuff. There's not a lot of those other cannabinoids in the market yet.
Oh my gosh, if we really did this well, what we would do is we would start to create a degradation cycle within a cannabis strain and create a true indica that's high in CBN produced in the plant that would then start to have people really mellow and deal with anxiety because of high CBN. CBN is a degradation product of THC. So let's be clear. If you leave pot sitting out with energetic oxygen, sunlight, and heat for periods of time, you will degrade delta-9 into CBN. Are there any plant strains out there that are super high in CBN? On the marijuana side, not very many. In fact, almost none. On the CBD side, there are more. There's a couple companies out there that are specifically trying to do genetics for that. I know of one right now. They have not perfected it yet. So what I would say is there are a couple companies, processors in the state of Utah who are degrading Delta-9 to create higher levels of CBN. Zion is one of those that does that. There are also some CBD strains that have higher CBN, and if you're going to mix your cannabis, your Delta-9 with one of those distillates, probably you'll get a good effect there. Those are the two best ways to get your CBN right now. Zion is the only one I know of that is actively doing that to add to medical products, but I'm sure there's others. That's not to say no one else is doing that. I know we do that actively.
What other cannabinoids are good for mental health? You've talked a little bit about CBN being good for mellowing. It tends to be a little anti-anxiety. At least that's the report, right?
Yep.
These other minor cannabinoids, we don't know. We definitely don't know as much about them. But CBN seems to be good for anxiety and sleep.
Yes. There is a lot of data that's starting to come out around CBC that shows that it affects energetic interactions in the brain, so it could be effective for seizures and energetic seizure conditions, even things like Parkinson's. So CBC is a good candidate for that. There are ones that restrict appetite. There's ones that enhance appetite. And so we can talk about those, and that's happening literally at, the brainstem area. It seems to be where it's doing most of absorption because it's regulating appetite. There are some that seem to give you strange dreams. There's one, I just read an article about a cannabinoid that I don't know almost anything about that's being tested right now in Germany. And it helps sleep. It changes sleep. So to answer your question, we need more data. Zion specializes in the cannabinoids that I know of, and we try to isolate those and put those into specific products.
Okay. Well, thanks, Blake. I want to let everybody know that, we're going to do, if you want a video and you want information about a specific product or product-related things, we are working on our list of topics for our next phase of educational videos with Discover Marijuana, and they're going to be with a pharmacist. We're going to have a pharmacist on with us, and we're going to talk more about the products. So if you want info or videos with Blake and I and a pharmacist in Utah to talk about products, put those in the comments, reach out to us. And second,
and I'm also happy to talk about any products. They don't have to just be Zion products because the science is the same. If they have a certain amount of cannabinoid content, we can talk about that very,
we can
unbiasedly.
Talk about
I hope everyone gets the sense that I'm here for the science, so that's kind of my deal.
Right.
I mean, I like my products, don't get me wrong. I think we do a good job, but science is what's
if
cool.
If somebody has a good product out
if
there,
they have
we
a good
want
product,
to talk about it.
We should talk about it because the patients
definitely
need it.
Yeah.
That's right.
Secondly, Delta-8. Blake and I are going to do a short, separate webinar. We're going to record it specifically about Delta-8. We're going to put it out there. We're going to talk about how Delta-8 is made, derived, what portion of it comes from the plant, what it's good for, where it meets in the body. We need to have a specific video about Delta-8, so that's coming.
And we should also talk about Delta-10, Delta-6, and Delta-11, and maybe THCP as well in that video.
Ooh, nice. Okay, so a Delta video.
A Delta video.
Remember to like and subscribe. Follow us, zionmedicinal.com, utahmarijuana.org, Discover Marijuana on YouTube. You can follow us and comment on all of our social channels. We're just happy to be here with you, answering your questions, giving you kind of the straight shot.
The skinny, as best we know it.
Yep. Thanks for watching.
Thanks. You're also silent.